सो हम स्टार्ट करते हैं फ्रॉम डायग्नोसिस क्राइटेरिया. दिस इज़ क्वाइट सिंपल. हम इसको याद रख सकते हैं विद द निमोनिक DKA. D stands for diabetes. When your blood sugar is above 200 mg per dl. K stands for ketones. When serum ketones are above 3 millimole per liter, or urine ketones are 2 plus. And A stands for acidosis. When you have serum pH of less than 7.3 or serum bicarbonate of less than 18. Then there is admission criteria, on the basis of which you will decide patient needs admission on the floor, ICU or MSD. So we have mild decay, in which serum pH is between 7.25 to 7.30 and serum bicarbonate between 15 to 18. These patients needs admission on the floor. And then moderate decay, when the pH is between 7.0 to 7.25 and serum bicarbonate between 10 to 15, these patients need admission in MSD or ICU. And then there is severe decay, when the pH is below 7.0 or serum bicarbonates are below 10. These patients also need admission in ICU. Then we have assessment and monitoring. At 0 to 1 hour, you have to check hydration status of the patient, monitor vitals, blood glucose levels monitoring, serum and urine ketones, and electrolyte monitoring. Then at 1 to 2 hours, same vital monitoring, glucose monitoring, electrolytes, and pH monitoring. Then from 2 hours to until resolution of DKA, you have to check vitals 1 hourly, you have to check blood glucose levels 1 hourly, and then you have to check electrolytes, venous pH 4 to 6 hourly. Then comes the management. Initially you have to give IV fluid bolus of normal saline 20 ml per kg. So if a patient is of 70 kg, you have to multiply that with 20, that equals to 1400 ml. Then after that you have to continue maintenance IV fluids. The fluid of choice is normal saline. You have to give it with a rate of 250 to 500 ml per hour depending upon the hydration status of the patient. And then when your serum glucose reaches 200 mg per dl, you have to change normal saline to dextrose 5% with normal saline at 150 to 250 ml per hour, but not more than 6 liter in 24 hours. Then comes the potassium. So this is quite interesting, because when we give insulin, it pushes potassium from the blood to intracellular space. And in diabetes, your potassium serum is also quite low. So can anyone from the audience tell me why serum potassium is low in diabetes? Anyone? It is quite interesting. So if any one of you who knows why serum potassium is low in diabetic ketoacidosis, so let me tell you, because of increased urination. With glucose, potassium also travels and get lost from the kidneys via urine. So when your serum potassium is less than 3.3, you have to hold insulin infusion and give 20 to 30 MEq of KCl until your serum potassium is above 3.3. And if your serum potassium is between 3.3 to 5.2, you have to continue KCl in each liter of IV fluid to keep serum potassium between 4 to 5. And once serum potassium is above 5.2, then you do not give KCl, but you have to check serum potassium every 2 hourly. Then comes the insulin, which is the main management of DKA. So you have to give insulin glargine, which is long acting, with the brand name of Lantus, 12 units stat, and then once daily. Then you have to continue insulin infusion of Humulin R or Act Rapid at 0.1 unit per kg per hour. So if a patient is of 70 kg, you have to multiply that with 0.1, that equals 7 unit per hour. And when your serum glucose reaches 200 mg per dl, you have to reduce regular insulin infusion to 0.02 to 0.05 units per kg per hour, which is 1.4 to 3.5 units per hour. And you have to keep serum glucose between 150 to 200 mg per dl until resolution of DKA. Then comes bicarbonate. So you do not give bicarbonate until advised by the consultant, or your serum pH below 7, or bicarbonate less than equals to 4. And then you can also start thromboprophylaxis, which we usually give for DVT prophylaxis. We can give heparin or clexane, and you have to identify the underlying etiology of DKA and you have to manage that. Suppose if patient is suffering from sepsis, or there is other non-compliance of the medication, so you have to treat that as well. And then you have to get endocrinology team on board within 24 hours. And then discharge criteria. When the patient DKA gets resolved, so when you say that DKA is resolved, that is when blood ketones are less than 3 millimole per liter, serum pH above 7.30, or serum bicarbonate above 18 millimole per liter. So guys, let's have a discussion. If you guys have any question, you can ask. We can have a discussion. If any one of you has any question, you can ask, please. I would love to answer your questions, love to answer your queries. आप लोग क्वेश्चन पूछ सकते हैं जो भी है रिलेटेड टू डायबिटीज़ या डायबिटिक कीटोएसिडोसिस. So any questions? Guys, let me know आप कहाँ से chat join कर रहे हैं. You guys are from which country, which part of the world? Are you from Pakistan, India, Nepal, UK, USA? Let me know. And I would love to answer your questions if you guys have any. So DKA, if not timely treated, can be deadly. What type of ketone bodies are present in DKA, if any one of you knows? What type of ketone bodies are present in DKA? So anyone who knows the answer? These are beta hydroxy butyrate.